We'll try to understand briefly regarding assessment of one important electrolyte abnormality called as hypokalemia. Hypokalemia. Imagine a patient coming with a blood report showing potassium levels less than 3.5 milliequivalents per liter, and then how we should go forward this in a very brief fashion. So patient coming with blood report of potassium levels less than 3.5. So what is the next step to do? The next step is always assess patient's urinary spot potassium levels. Urinary spot potassium levels. Why urinary spot potassium levels are assessed? This is assessed to understand the status of the kidneys. What if the urinary spot potassium levels is less than 15 milliequivalents per liter of the urine? So, and one more case is urinary spot potassium is more than 15 milliequivalents per liter. So imagine that patient's tubules which are present in the kidney are completely normal. So they are able to reabsorb enough amount of potassium. Then the urinary potassium levels will be very less or normal. So here, if the urinary spot potassium levels is less than 15 milliequivalents per liter, then we can understand that the tubules of the patient are completely intact. Tubules of the kidneys of the patient are completely intact. So here pathology lies somewhere other than the kidney. So what if the tubules of the patient's kidneys are unable to reabsorb enough amount of potassium? Then in this case, the pathology lies in the kidney, that the tubules of the kidneys are unable to reabsorb. Hence they throw out excess amount of potassium, leading to status of hypokalemia. Hypokalemia. So here the patient urinary potassium spot potassium levels shows more than 15 milliequivalents per liter. Then we came to one conclusion, that there is a abnormality in the tubules. Then how to understand which tubules are abnormal, which tubules are completely intact? The next step here is understanding ABG, that is arterial blood gas analysis. So why it is done? ABG is done to understand whether the patient in a state of acidosis or patient in state of alkalosis. So what if the patient is having acidosis with urinary spot potassium levels more than 15? We understood that pathology lies in the kidney, patient is having hypokalemia. So here the pattern becomes hypokalemia with ABG analysis showing acidosis. How we should go with forward? So this spectrum of diseases where patient is having acidosis with hypokalemia is known as RTA, that is renal tubular acidosis. The tubules of the kidney are completely abnormal here. So since the tubules are completely abnormal, the potassium is not reabsorbed. That is the first point, leading to hypokalemia. And even there is an abnormality in handling H plus levels, leading to acidosis. So there are two important types here, that is RTA type 1 and RTA type 2. RTA type 1 and type 2. Why it is classified? Because in RTA type 1, the proximal segment of the nephron is completely normal. That is the status of the PCT, which reabsorb most of the electrolytes and other components of the GFR. Here the proximal segment is completely normal, and the pathology lies in collecting ducts of the nephron. So here in RTA type 2, what happens? In RTA type 2, the distal segment, that is collecting duct and the later DCT part, is completely normal, but the problem here is PCT. The proximal segment of the nephron pathology lies there, leading to inefficient or incomplete reabsorption of the electrolytes, leading to hypokalemia. So what if the patient is having alkalosis and hypokalemia? Here the next important step is checking the blood pressure of the patient. So in this, again, two possibilities. One, patient is having raised blood pressure, that is the first reason, and patient is having normal or low blood pressure. What if the patient is having high blood pressure with alkalosis with hypokalemia? So this becomes three important spectrum of diseases which the patient is having. One, hypertension; two, alkalosis, that is metabolic alkalosis; and three, hypokalemia. So we'll write in short format that patient is having hypertension, alkalosis, and hypokalemia. So this spectrum of three important components, that is hypertension, alkalosis, and hypokalemia. There are three important differential diagnoses here. One is Liddle syndrome. Next one is Cushing's syndrome. Next one is Conn's syndrome. So these are the three important syndromes which comes with three important triad of clinical feature, that is hypertension, alkalosis, and hypokalemia. What if the patient is having alkalosis and hypokalemia, alkalosis, hypokalemia, and normal to blood pressure? So the two important differential diagnosis lies here. The first important differential diagnosis here is Bartter syndrome. Bartter syndrome. Next one is Gentleman syndrome. Gentleman syndrome. So, in briefly, I will again explain that patient came with a blood report less than 3.5 milliequivalent per liters of potassium. So that becomes a case of hypokalemia. The next step is assessment of urine spot potassium levels. This is done to assess the status of the kidneys. What if kidneys are throwing out excess amount of potassium? So in that, we came to know that the tubules of the kidneys are completely abnormal. So next step is assessment of the ABG. In the ABG, if the ABG report shows acidosis pattern, then there are two important differential diagnoses. What are these? RTA. In RTA, there are two important differential diagnoses. What is this? RTA type 1 and RTA type 2. In the RTA type 1, the problem lies in the distal segment, that is collecting part of the kidneys. In the RTA type 2, the problem lies in reabsorptive part, that is proximal segment, nothing but PCT is the problem. So patient is having again hypokalemia with arterial blood gas analysis showing alkalosis pattern. So next immediate step is checking the blood pressure of the kidneys. If the blood pressure is high, that is hypertension. So the clinical spectrum, that is hypertension, metabolic alkalosis, and hypokalemia. There are three important differential diagnoses. What are these? One is Liddle syndrome, Cushing's syndrome, and Conn's syndrome. So all these three diseases come with a important spectrum, that is hypertension, metabolic alkalosis, and hypokalemia. What if the patient is having low to normal blood pressure, that is hypokalemia and alkalosis with normal to low blood pressure? Again, there are two important differential diagnoses, that is Bartter syndrome and Gentleman syndrome. So this much is sufficient regarding assessment if the patient urine spot potassium level shows more than 15 milliequivalents per liter of potassium. What if the spot potassium is less than 15? So in this, the kidney is completely normal, pathology lies somewhere else. Where the pathology lies here? Here, one important term is used, that is transcellular shift. Transcellular shift, meaning that the potassium, which is important component of intracellular level, that is potassium is part and parcel of intracellular electrolyte. If some drugs cause excessive amount of potassium to be thrown out from the blood. So imagine this is the blood column and this is the cellular column. Imagine any drugs or conditions which throw out potassium from blood to cell. It is known as transcellular shift. Or one more case is that normally some amount of potassium is also thrown out from inside the cell to blood. So if that process is also hindered, that gives hypokalemia status. So here important clinical conditions to know is beta agonist. Beta agonist. So beta agonist drugs such as salbutamol cause transcellular shift of the potassium leading to hypokalemia. And next one is alpha antagonist. Alpha antagonist. Next is salbutamol, alpha antagonist, and insulin. So these are the very important examples of blood levels showing hypokalemia, which will cause transcellular shifting. So how to assess all these things and how to differentially diagnose these three things, we'll understand in the next video. Thank you.